Welcome to the Deep Dive. We take your sources, articles, research notes, and boil them down to get you quickly up to speed. Today we're diving deep into distal tarsitis in horses. It's a common cause of lameness, but it can be a bit confusing. This deep dive is really tailored to help you understand it, cutting through the noise to get to the core insights. Okay, so let's unpack this. What exactly is distal tarsitis and, why is it such a big deal for horses? Well, at its core, it's a lower hock joint lameness issue. You've probably heard it called bone spavin around the barn. We're essentially talking about pain, inflammation, maybe even osteochondral damage, that's bone and cartilage damage, in the low-motion joints of the hock, specifically the distal intertarsal, the DIT, and the tarsometatarsal or TMT joints. Yeah, think of them as the small, less mobile joints down low in the hock. They are just really prone to compression, rotation. And when they get hit with excessive or repetitive forces, well, that often leads to inflammation and eventually osteoarthritis.
Right. And the really critical thing to understand is why these small joints cause such problems. They play a huge role in absorbing shock and transferring force through the hind limb every single step. I mean, think about the impact during a gallop or a jump or hard stop. The repetitive trauma is immense, and these joints really take a pounding. And it's also worth mentioning juvenile bone spavin. That can show up in foals. Often it's because those small tarsal bones haven't fully ossified or hardened on schedule.
That's interesting about the foals.
Yeah.
But mostly we see this in horses of pretty much any age, right? Though middle-aged athletic horses seem to be the most common group affected. And here's something that surprised me from the sources. It's actually quite rare in ponies and donkeys, mules, even draft breeds.
Yeah, that is an interesting observation. Definitely seems linked more to certain types of athletic use.
So, if you're listening, how do you even start to spot this? It could be subtle. What are those historical clues or the physical signs that might point towards distal tarsitis? Historically, owners often report this kind of intermittent, slowly worsening hind limb lameness. It can be one leg, but surprisingly often it's actually bilateral, both hinds. And a real key characteristic, you hear this a lot, is that horses often warm out of it. They start stiff, maybe a bit sore, but seem to improve as they work.
That warming out is a big clue.
And performance-wise, you might see a drop, maybe slower times, a reluctance to stop hard, turn sharply, or jump. They might fight collection or struggle to pick up the correct canter laid. And one specific thing to look for is if they start dragging their hind toes.
Exactly. And building on what the owner sees, when the vet does a physical exam, we look for more specific things. You might feel, or sometimes even see, a bit of bony enlargement and exostosis, maybe some heat over the inside part of those lower joints, the TMT or DIT. The gait itself can be quite characteristic. It's often described as stabbing or stabby. The limb tends to swing inwards towards the midline, and then the foot lands towards the outside.
Oh, okay.
And a telltale sign on the shoe is often a worn lateral toe on the hind foot. That's from that landing pattern.
I see.
Lameness also often gets worse after we do certain upper hind limb flexion tests, and sometimes pain can be triggered by the Churchill test. That's specific pressure applied to the inside of the cannon bone near the hock while pulling the leg outwards. It really tries to isolate that spot.
Gotcha. So here's what I found really interesting. What causes it? What are the underlying risk factors? Our sources pointed to a few key things.
Yeah.
Poor conformation is definitely a big one. Things like sickle hocks, cow hocks, maybe a really straight hind limb conformation, even having a long toe and low heel on the hind foot, or a significant height difference between the withers and croup. These can all predispose a horse.
Yeah, conformation is huge. It affects how forces are distributed.
And then there are the specific athletic activities, right? Jumping, sharp stops, anything involving a lot of hind limb effort.
Absolutely. High impact, repetitive strain.
And like you mentioned with the foals, that delayed bone ossification in the small tarsal bones. Plus, excessive exercise when they're very young seems to be a factor too.
Yes, pushing them too hard, too soon before those structures are fully mature.
Okay, so we know what to look for. We know some potential causes.
Yeah.
But how do vets actually diagnose it? Our deep dive showed it really needs a systematic approach. It's not always straightforward. The clinical signs can be subtle, and this is crucial. What you see on x-rays doesn't always match how lame the horse is.
That's a really key point. The correlation can be poor.
So where does the investigation start? Usually with a detailed history, right? The vet needs to know how and when the lameness started, how it's progressed. Is it gradual? Intermittent? Does it warm out? They'll ask about performance issues, the horse's age, conformation, all those background details.
Exactly. Then comes the lameness exam itself. The lameness is typically most obvious at the trot. You might see that shortened forward stride, the cranial phase. That stabbing gait we talked about with the foot landing outside is common. And you might notice a clear hip hike or more pelvic movement on the lame side. Often the lameness gets worse on a circle, particularly with the affected leg on the inside of the circle. And then there's the classic Spavin test. That's where you hold the hind limb flexed up tight for, say, 60 to 90 seconds, then immediately trot the horse off.
Okay.
Now, this test is very sensitive, meaning it's good at picking up a problem if one exists, but, and this is important, it's not highly specific. Meaning other hind limb issues, like stifle problems or suspensory issues, can also cause a positive flexion test. It flags the hock region, but not definitively distal tarsitis.
Ah, okay. So it points you in the right direction, but it's not the final answer.
Precisely. So how do we pinpoint it?
That's where diagnostic analgesia comes in, right? The nerve blocks and joint blocks.
Exactly. That's really the gold standard for diagnosis.
Vets inject local anesthetic directly into those lower hock joints, the DIT and TMT. And if the horse's lameness significantly improves, usually within 5 to 15 minutes,
then you've confirmed the pain is coming from those specific joints.
And a key detail our sources mention is that these two joints, the DIT and TMT, they only communicate in about 30% of horses.
Right. Which means you often need to block both joints separately to be sure you've numbed the source of pain. You can't assume blocking one will numb the other.
Makes sense.
Yeah.
So once the block confirms the hock is the issue, what's next? Imaging.
Yes, imaging is the next step. Radiography, x-rays are usually the first line.
And what might those show?
Well, in early disease, the x-rays might look surprisingly normal or show only very subtle changes.
Okay.
In more severe or chronic cases, you might see obvious signs like bony proliferation, that's the exostosis, or bone spurs, or even ankylosis, where the joint has started to fuse naturally.
But you said earlier the x-rays don't always correlate with lameness.
Exactly. And this is the aha moment for many people.
Yeah.
The severity of radiographic changes often correlates poorly with how lame the horse actually is. You can have horses with really quite dramatic bony changes on x-ray that are performing soundly.
Yeah.
And conversely, you can have horses that are significantly lame with only minimal, subtle changes visible on their radiographs. It's fascinating and often surprises owners.
Definitely counterintuitive. So what other imaging might be used?
Well, nuclear scintigraphy or a bone scan can be very useful. It highlights areas of active bone turnover or inflammation. So you might see a hot spot in the distal hock joints, even if the x-rays look fairly clean. It shows active inflammation.
Okay.
For really complex cases, or if other diagnostics aren't clear, MRI gives amazing detail of both the soft tissues and the bone, especially the subchondral bone just beneath the cartilage.
And ultrasound.
Ultrasound has limited use for looking directly inside those tight distal tarsal joints themselves, but it's very helpful for evaluating the surrounding soft tissues, ligaments, tendons, joint capsule around the hock.
Got it. Any other diagnostic pieces?
Sometimes you might look at pathologic findings if available, perhaps from previous surgeries or postmortem, which could show things like joint fusion, areas of bone loss, or cartilage damage directly.
Okay, so once you have that diagnosis confirmed, what are the treatment options? Our sources made it clear it's usually a multimodal approach, not just one thing.
Absolutely. The goal is always to reduce pain and inflammation, try to slow down the disease process, and keep the horse comfortable and performing if possible.
So where do you typically start? Conservative management.
Yes, usually. That often involves an initial period of rest, maybe hand walking, followed by a very careful gradual return to controlled exercise.
And shoeing seems critical.
Hugely important. Corrective farriery is paramount. This might involve shortening the toe to make breakover easier, maybe raising the heel slightly, using specific shoes or pads to improve the foot balance and reduce strain on the hocks. It's about optimizing biomechanics.
Right, changing how the forces go through the leg.
Exactly. Then we move on to medications. Systemic NSAIDs, non-steroidal anti-inflammatories, are common. Things like phenylbutazone or bute, flunixin, or sometimes firecoxib, which is a COLEPS-2 selective NSAID.
Why Kyoga's too selective?
It targets the inflammatory pathway more specifically and theoretically might have fewer side effects, especially on the gut, with long-term use compared to traditional NSAIDs.
Okay.
But really, the cornerstone of medical management is often intra-articular medication, injecting directly into the affected joints.
What gets injected?
Most commonly, corticosteroids. They're powerful anti-inflammatories. And because the DIT and TMT are low-motion joints, there's generally less concern about potential negative effects of steroids on cartilage compared to injecting high-motion joints like, say, the stifle or fetlock repeatedly.
I see. So the low-motion nature is key there.
Yes, and often hyaluronic acid, or HA, is injected along with the steroid. HA is a natural component of joint fluid, so it helps with lubrication and also has some anti-inflammatory effects itself.
Okay, so steroids and HA are common joint injections. What else is in the toolbox?
Well, there are polysulfated glycosaminoglycans, or PSGEGs. Equine is a common brand name. These are usually given as intramuscular injections and are thought to help protect cartilage and improve joint fluid quality. Then you have the biologic therapies. Things like IRP interleukin-1 receptor antagonist protein, or PRP, platelet-rich plasma, or even stem cells. These use the horse's own blood or tissues to generate anti-inflammatory substances or growth factors to encourage healing within the joint.
More natural approaches, kind of harnessing the body's own systems.
Exactly. And then there are the oral joint supplements, glucosamine, chondroitin sulfate, MSM, omega-3 fatty acids. Lots of options.
Do they work?
The evidence for oral supplements in cases of established osteoarthritis like distal tarsitis is, well, it's variable according to our sources. Some horses seem to benefit, but strong scientific proof can be lacking for some formulations.
Okay. Anything else medical?
Bisphosphonates, like Tildren or Osphas, are another class of drugs. They work by slowing down bone resorption, the process where bone is broken down. In conditions like this, they can help reduce bone inflammation and stabilize the bone remodeling process in the affected joints.
So quite a few medical options. But what if those aren't enough? What if the horse is still lame?
That's when we start considering more advanced or surgical management, usually for cases that are refractory, meaning they don't respond well to medical treatment.
And what does that involve?
One option is chemical arthrodesis, essentially inducing the joint to fuse using chemical agents. Substances like sodium monoiodoacetate MIA or sometimes ethanol are injected into the joint.
That sounds intense.
It can be. It basically destroys the remaining cartilage and triggers an inflammatory process that leads to bony fusion. A key thing to know is that these injections can cause significant pain and swelling in the short term, so managing that pain aggressively right after the procedure is crucial.
Right. And besides chemicals, actual surgery.
Yes, surgical arthrodesis aims to achieve the same goal fusion but through mechanical means. Techniques involve drilling small holes across the joint space to stimulate bleeding and bone growth, sometimes guided by arthroscopy. Laser-facilitated arthrodesis is another technique, using a laser to ablate cartilage and stimulate fusion. Less commonly, plates or screws might be used, but usually not for these specific small joints.
Any other procedures sometimes mentioned?
Historically, a cunion tenectomy was sometimes performed. That involves cutting a small tender, the cunion tendon, that runs over the inside of the hock. The theory was it relieved pressure, but its actual effectiveness for distal tarsitis is now considered pretty debatable by many vets.
Okay.
And then as a salvage procedure, really a last resort for chronic pain, there's neurectomy of the deep fibular nerve. That involves cutting the nerve supply to the area, which removes pain sensation, but also removes protective sensation, which carries risks.
Right. That sounds like a significant step.
Right.
And all these treatments must have potential downsides.
Absolutely. We mentioned the pain with chemical fusion. Intra-articular steroids shouldn't be used in horses with a history of laminitis. Chronic NSAID use carries a risk of gastric ulcers or kidney issues. Any joint injection carries a small risk of infection, so benefits always have to be weighed against risks.
Makes sense. So let's talk prognosis. What's the long-term outlook for a horse diagnosed with this?
It really varies, as you'd expect. Depends on the severity, how lame the horse was to begin with, the x-ray changes, and importantly, what the horse is expected to do its job.
So maybe good news for some.
Definitely. The good news is that many horses, especially those with early or mild distal tarsitis, can be managed very effectively. With consistent medical management, maybe periodic joint injections, good farriery, appropriate work, many can return to their previous level of performance and stay comfortable for a long time.
That's encouraging. What about the more severe cases?
For horses with chronic issues or significant bony changes on x-rays, the prognosis for returning to high-level demanding athletic careers might be more guarded. However, even many of these horses can often be kept comfortable for pleasure riding, trail riding, or less demanding work.
And what about the fusion procedures? You mentioned those for refractory cases. How successful are they?
This is where it gets really interesting, actually. For horses that just aren't responding to medical management, Fusion, either chemical or surgical, can be remarkably
Well,
successful.
how successful?
The success rates reported in our sources are pretty high. For chemical fusion, achieving soundness is often reported in the 75–85% range. For surgical drilling techniques, it's often around 60–80%.
Wow, that's quite good for horses that weren't responding otherwise.
It is. And the key thing here is because the DIT and TMT joints are naturally low motion joints,
Right.
fusing them doesn't typically cause a major change in the horse's overall gait. Once the fusion is complete and the inflammation has settled, you're basically eliminating the pain source by making those small joints solid.
So they become sound because the painful movement is gone.
Precisely. It creates a stable, pain-free situation in that specific area.
How long does that fusion process take, say, after surgery?
It's not a quick fix. Full bony fusion and recovery after surgical arthrodesis can take quite a while, often in the range of 10 to 12 months before the horse might be back in full work.
Okay, so it requires patience.
Definitely. And like any procedure, there can be complications. Sometimes horses develop temporary lameness in other limbs as they compensate during the healing process, but that often resolves once the hock itself is pain-free and stable.
So if we try to tie this all together,
Yeah.
what's the main takeaway message from this deep dive? I think if we connect this to the bigger picture, it seems like early diagnosis is really key. And then an aggressive multimodal management plan combining things like those joint injections when needed and really focusing on that corrective therapy, that approach can make a huge difference for the long-term comfort and usefulness of these horses.
I agree completely. Proactive and consistent management is vital.
And it's also good to know that for those tougher cases where medical options fail, fusion is a very viable and often successful path forward. It's not the end of the road.
Not at all. It can give many horses a new lease on a comfortable life.
We really hope this helps you, the listener, reflect on how understanding the details, even things like subtle gait changes or that weird disconnect between x-rays and lameness, empowers you to make better decisions for your horse's health. And maybe it leaves you with a final thought to consider. If even these low-motion joints in the hock can cause such significant lameness and require such complex management, what does that suggest about all the other hidden stresses and the incredible compensatory mechanisms happening throughout an athletic horse's entire body, day in and day out? Something to think about. Thank you for joining us for this deep dive.